so okay, hold on. Everyone who's on the meeting, some of the questions I purposely have constructed a little bit relative to a nuance within the question. So even though hopefully you will learn the answer if it's wrong, if you missed it, and you will learn that, but also try to learn from what I'm trying to say regarding maybe the construct of several of these questions that I purposefully did certain ways just to point out again how you read a question, if you will. Now, this is the last board review, especially for the third years, because the next board review is like in August. I think we pick up again. So this will be the last one. So let's start with the first question. This actually is a question that's simply database with a perfectly wonderful pattern recognizer in it. It's the reconstituted powdered formula. I mean, that is your pattern recognizer. That's what you key into. And so therefore you either know this or you don't. And so it's a more of a database question. But my point is to be sure you read that particular commentary because that's the key. And so the answer is D. And this is a bug that grows in formula that has been powdered, reconstituted. It's kind of a classic. The Citrobacter, remember, is multiple brain abscesses. Right. And you could say, well, that would be an organism that a 2-week-old could get because the neonates get them. You're exactly right. But once again, proving the point of the pattern recognizer, and the pattern recognizer being the reconstituted powdered formula. So it's D, Enterobacter Sasaki. Okay, next, 5-year-old to the ER. Most of you got this. I think if you're looking at this question, you should have gotten it down to, based on the stem of the question, either Ebola virus or dengue. Now, there are a couple of things that could go either way, and I would argue that perhaps both are the answer or could fit the stem of the question. But the most likely, now what makes it be most likely regarding the two answers? And the two answers are B and E. You should have gotten it down to B and E. If you didn't get to B and E, then you need to read some more about more that's in the stem of that question. So India obviously is a big ticket item here. Zaire is in Africa. Doesn't mean that they may not have Ebola in India that they do, but on a test question, the classic Ebola would be an African person because they're not going to go for that weird place that it might be found. So using the term India should help you. And of course, the giveaway here is the pain with eye movements. This guy's again, dengue. Retroorbital pain. That's your big key. That's your big thing that separates these others. Because frankly, the labs could go with either. They actually probably could go with A for that matter. But once again, summer, that could fit for tick, but why are we in India? So it's kind of like you say, well, if they're phrasing a question like this, if Rickettsia would be the answer, why would they have made the patient in India? Once again, just showing you why is India there? And it helps you parse through the answers that might be possible and then increase the odds of getting it right. So this answer is dengue. Number 3, this is just a database question on Hep C. Please, those third years who are finishing, please read about Hep C. It's the latest, greatest, meaning for testing. Now, you know, tests are always 2 years behind, but the Hep C, those issues have been out there for a while. So my suspicion is that you'll have a Hep C question and you just got to learn some of the basics. So I put a couple on here, but please review Hep C for the upcoming boards. And the answer here is that the breastfeeding is recommended if the mother doesn't have HIV relative to Hep C, if you will, okay? So that's just a database. Next. Okay, now this question is again just knowing the prophylaxis for Neisseria. That's basically what it's asking. And rifampin is the answer. And why is that? Because rifampin gets into the nasal secretions. That's really the answer. I'm not saying that penicillin doesn't treat the bug. That's not the point. You're trying to get rid of the organism in the nasopharynx. So you're giving a drug that not only is the bug sensitive to, but that drug gets into that area, which is what you are trying to accomplish, because you're trying to remove it being spread among individuals, not only to the brother himself, if he has it there, but also for his ability to give it to others above and beyond his twin brother. So rifampin is your classic answer for secretions and prophylaxis, okay? Number 5, pretty straightforward here. You know, oral therapy for that diagnosis, which is your tinea capitis, maybe a carrion there, and that's going to be oral. You know, topical doesn't work, and it's oral. Griseofulvin is kind of your first line answer on that, and I think most of you got that. And again, I do have the numbers here regarding who missed more than half, so I'm flying through some of these more quickly so that we can spend a little more time on those that y'all missed a lot of which there are about, 8 of those. But none of these thus far. Number 6, this again, a hepatitis C, and you look at 2 months of age and you do the NAAT to see where the baby is in regards to this baby being infected. So this classic answer is A for hepatitis C. Number 7, Whitney, number 7, okay. A 3-year-old comes in, altered mental status, etc. And you read the question, and again, you obviously hopefully saw elevated white cat, 98 polys, low glucose, high protein, so this should be bacterial. Could have been tuberculosis, but acute TB meningitis would be more chronic. So everything fits, just kind of a classic, if you will. But the question isn't really that. And again, if you were a slow test taker, this would be a classic question where look at what they're going to ask, then go back and read the stem, because you may start reading it and say, oh, well, I know this is going to be pneumococcus, or I know, well, but that's not the question. The question ends up being, so just serve as an example, the culture result that most strongly indicates the need for chemoprophylaxis is what? Well, if you look back, the only one is your H flu type B. That's the classic studies. That's the one that you is in the literature. Now, had Neisseria been down there, then that would have been an answer, but it's not down there. So of the 2 of the answers that are there, it's Haemophilus. Number 8. Now, this is one that y'all missed a few of, and basically you should have gotten this answer down to either A, isolate the infant and mother, and D, the correct answer, separate the infant from the uncle. And this requires you kind of to think tangentially a little bit, because you do have to be prepared to know that the mother may have tuberculosis. I don't deny that. But to isolate her, the question is, what is the best management for the newborn and not for the overall public health or overall? And so for the newborn is certainly to keep the newborn away from someone who you infer would have tuberculosis, which would be the uncle. So I can understand you putting down isolate the infant, and the mother, because at least they didn't say from the mother. Now that would have been the wrong answer unless you knew the mother had tuberculosis, which you don't. So the isolate the infant, not a bad answer. Second best answer, got it. The others are clearly wrong, and if you answer those, then you need to read about tuberculosis in the newborn. But the isolation of the infant and the mother, I mean, what you're isolating them, what? Are you waiting for somebody to get sick? Now, had they put down place a PPD on mother, okay, then that might be a good answer. But the point of placing the TB skin test was on the baby, which you would not do. And again, on the newborn. Would it be wrong to get a chest X-ray on mother? Not bad. Again, you would hope that the patient would have symptoms, the mother would have symptoms. So this question kind of has a little bit of intuitive answering between the two. Again, you should be able to get it to those two. And then you have to think through it a little more practically to understand that the best management is just to keep the infant away from someone that is giving you every sign and symptom that they have tuberculosis. Okay. But I can see how A would have at least crossed your mind. Not a bad answer. Number 9, this is a dog bite, but of course, what's the hooker in this question? The hooker is that he's allergic to amoxicillin. Diffuse pruritic. Now, had they not said pruritic, then you could say, well, are they just trying to trick me and this is an amoxicillin rash? Hence, he's really not allergic. Hence, amoxicillin clavulanate, augmentin would have been the classic answer for dog bites. So there's a key word here. Again, put this question in with that key word, trying to get y'all to read keywords, because you could have easily glossed over that they're just trying to go for an amoxicillin rash, which is a big bunch of nothing. But when you see the word pruritic and this rash, then the inference is he's allergic, potentially allergic. So then you have to look. And if you go to the red book and look, it sits right there. It says, if you're allergic, what do you do? And the answer is E, you give them clindamycin and trimethoprim. I mean, it's right there in the red book. There's no ifs, ands, and buts about it. And again, the red book, remember, is the ID Bible. They're going to resource the red book for answers for ID. So if you're looking for something to augment your education regarding ID for the boards, the red book is what they're going to go by. And many of y'all missed this question, so that's why I want to be sure. And the trick is you might have just tried to fall for that amoxicillin rash, but it's the word pruritic, and I know I'm repeating myself, but I'm just trying to make the point. You have to read the words that are there. You can't just gloss over them. Number 10. Okay, and this is, from me. So Liz will be happy, because had I not put a question about atypical mycobacteria, she probably would have jumped down my throat. So here it is, and you have to read it, and you understand that this is an atypical mycobacteria, and the treatment is remove the node. I mean, it's remove the node. That's it in and of itself. So obviously that answer is D for your atypical. That's scrofula, okay? And you look at that with a 4-week history. I mean, it's been chronic, and and she doesn't have cancer, no hepatosplenomegaly. So again, look at the pertinent negatives in here. No hepatosplenomegaly, no diffuse lymphadenopathy, nothing else. So, you use those negatives to help you with some of the answers. Could it possibly be, even though the negatives, sure. But if you're going to play that game on a test, they're putting negatives in to help you say the answers that some of the answers that would be there should have those not as negatives, but as positives. So again, that's a good test taker does it that way. They'll say, they shouldn't have said that's a negative if that's the correct answer. They would either not said anything at all, but when they say it's a negative, they're trying to say that's not the right answer. So this is an example of looking at your negatives to help you sometime with the answers. Number 11 is a 10-month-old to the ER with a buttocks abscess. Excuse me. And, I think everybody got that. This is kind of straightforward for, abscesses and MRSA, and you get the drift. Now, had Septra been down there, that would have been trimethoprim sulfate. That would have been a little bit tough, but it's not there. So the answer here is clindamycin. Number 12, congenital hydrocephalus. Now, this is a shunt infection. And you have to say, well, what is the number 1 bug? Well, they're already going to help you with gram-positive cocci, which you probably shouldn't have needed, because your Viridans strep, your staph epidermidis, it's your skin flora, because that's classically what happens when you get a shunt infection. Remember, shunt infections occur generally within 6 months of the shunt being placed. So you can still have those bugs 4 months after the shunt of the infection. If the shunt's been there for more than 6 months and everything's copacetic, then they get infected. Then you have to kind of morph those bugs a little bit into You know, maybe it's just got routine run-of-the-mill meningitis, just like anybody could have it. But gram-positive coccidin clusters, well, you know that's staph. And so of the two I just said, then that's going to be staph epidermidis. What is the treatment of staph epidermidis? It's going to be vancomycin, and that's your answer. Okay, for CNS. Okay, 13, influenza. She comes in. Well, this is your classic secondary invader to influenza, your bacterial infection. You know that classically that's Staph aureus. Classically that's going to be MSSA. Treatment of MSSA is nafcillin. I think that might have been a typo previously, but you know, it's on the answer, but it's nafcillin. And sometimes they will put in there methicillin too, and methicillin will get it, but in kids, you always worry about what side effect with methicillin. Interstitial nephritis. It's a classic. So always remember blood protein interstitial nephritis with methicillin. That's why the answer is nafcillin. Okay, even if both of those answers are down there. Number 14, you walk through this question. I mean, it's reeking that this is going to be pneumocystis, and then you have to look at the most likely test to yield a diagnosis. Now, in this question, I think it's fair for you to say, well, serologic, I mean, that could be a lot of stuff that I could do. Are you talking about PCRs and pneumocystis of blood and all that? And I'm with you. I got it. I think you have to look at the pediatric boards from a standpoint of, at this point, not big into all these panels that now are out there in terms of your quick diagnoses. If all of the answers are a panel, then forget what I just said. But generally, they're looking at the standard diagnoses, and for pneumocystis, it's going to be a bronchoalveolar lavage. And remember, you're looking for the nathinamine silver staining. That's your classic staining for pneumocystis. And that's been kind of the tried and true standard, meaning that as we get to some of these highfalutin tests now, since they're not necessarily standardized as the gold standard, if you will, just look at cystic fibrosis. I mean, it's still sweat test, even though you and I both know all of the DNA that you can do now. So the PEDS boards kind of is at that basic level of tried and true, if you will. So I understand if you put serologic study, but what does that mean, since that's a very broad thing? If you answered one of the other three, that's not going to be for the diagnosis, not for the assessment, for the diagnosis. Because I understand the CT might assess it, but the diagnosis would either be BAL or a serological study, with the answer being your BAL-B. 15, fever, diarrhea, vomiting comes in. Let's see, most of y'all got this. Because, I mean, what are you dealing with here? Okay, this is a gram-positive organism for a kid that has what? Pyelo, you know, UTI, whatever you want to call it. Now, she's been on trimethoprim, and things are not getting any better. So that, you have to factor that in to then what is the most likely diagnosis. Well, if you go back to your diagnoses of UTIs, you think of your gram negatives. Okay, classically, which Ciptra would get. You think of, you know, other bugs, but this bug's going to be positive. So you got to think of a gram positive. So then you can say, well, staph, okay, Ciptra, it's not bad for staph. And so probably not. What's your other bug for UTI? You should know that, Enterococcus. You would know that Enterococcus trimethoprim sulfate does not get strep, Enterococcus is a group D strep. What is the treatment? Ampicillin. Strep is an ampicillin drug. So the answer is A. But you have to look at this question. You can look at it from a couple of three angles that I just walked through, knowing the bugs, using the gram stain. Trimethoprim didn't do it. you process all that information, and ampicillin's the answer. There's no other way around it, because this is going to be Enterococcus UTI. 16, let me check our time. Okay, we're doing good. 10-year-old. All right, here we go in July. So now this question is a little tough, and I'm the first to admit it. So you have to read through this. And so we're in July, number 1, so that's good. We're in Wisconsin, number 2. Okay, we've been outside, number 3. But he's had no animal exposure that, you know, in terms of thinking through, like, I mean, here we're talking about like bats and, you know, known animal exposure. Certainly you cannot say he hadn't had a, you know, a tick bite or a mosquito bite, but they're talking about animal exposure, meaning a known animal exposure. So here's this kid. He's obviously got Koenigsberg burdensis. He's got, oh, and then they even tell you he's got mosquitoes. So once again, when they talk about animal, you can see how they're using the word animal. And here they tell you he does have mosquitoes. But the real clincher is to just interpret the CSF. Certainly it's abnormal, number 1. Number 2, it's got lymphocytes. Number 3, it's got just a little elevated protein. Number 4, it's a normal glucose. You know this is viral. That's viral. You may not know what it is, but you know it's viral. It's not bacteria. So of the following, what are you going to tell the parents? Well, put the viral into the upper part of the question, the July, the Wisconsin, this sort of thing. And you come up with the fact that he's got one of the meningoencephalitis caused by, you know, there's, goodness, I mean, there's even one named La Crosse, because that's in Wisconsin. I mean, that's kind of where a lot of this sort of thing occurs. And basically, they're not going to die. It's a meningo, it's a viral single abscess. You know, we're not talking about, you know, West Nile. We're just talking about the run of the mill up there, and they get well. And it tends to stick into the CNS, as opposed to some of your enteroviral meningoencephalitis, which can do that, where they may have in an addition like a myocarditis. So in this particular question, I understand how C might have been some of the answers for you, but you have to look at the bug there, Wisconsin July, is more just CNS. Whereas had the same patient presented elsewhere, depending on the stem of the question, myocarditis could have been an answer, because, you know, the enteroviruses can give you a meningoencephalitis with a myocarditis. So, yeah, but based on this, of the answers there, the best answer is going to be B, as in boy. 17. Now this is a good question, but most of you got it. So this is, you know, good. This kid is one, the petechial rash, the hepatomegaly, the jaundice. This is a mother who has syphilis and all this. And so the answer is D, the penicillin. I just wanted to be sure that you didn't go with the acyclovir for herpes. It should have crossed your mind. But then the petechial rash, as opposed to vesicular. Had it said vesicular, that would have made it tough for me, but it doesn't. And so of the answers, this is going to be PENG, which is the treatment of syphilis. 18, answer here, pretty straightforward, right? Chesapeake Bay, I mean, Rocky Mountain, hello, that's falling off a long question. Hopefully everybody got that. That's going to be doxycycline for Rocky Mountain spotted fever. Number 19, rhinorrhea for 3 days, increased work of breathing, you know, mild retractions, you got the clinical, hypertrophied lungs, but they say the RSV is negative. So he doesn't have RSV, and really what's the second, this is a database question, what's the second most common organism in a non-RSV classic bronchiolitis? And your database should know that it's human metapneumovirus. So the answer is C. 20, a lot of you missed. And this is a 13-year-old with a 2-day history of fever, rash, okay? She's got pharyngeal exudate, sandpapery rash. The group A strep is negative. Now, when they do that, don't try to say, well, that's a false negative. You know, and I understand carriers and I understand false negatives, but if they're going to give you something, like, you go with it. You say, there's no reason that I should not, unless the answers don't fit anything, then you may have to go back. But in general, you will say it's negative. She doesn't have strep. Okay. So she does have something because we're growing it. And you may not know what it is, but it's with all this sort of thing, this should be your Arcanobacter. And that, remember, something you always have to think about in the adolescent with a negative strep that looks like strep, meaning sandpaper rash, cervical nodes, etc., that it's Arcanobacter. If you want to culture it and get the results, I mean, in a big hospital would get it, but if you're trying to catch it in a small hospital, you would have to tell the lab to look for that, because it will grow in a little bit of a more fastidious manner. So you would want to alert the lab, listen, I need you to look for Arcanobacter. And the other trick behind Arcanobacter is it's a macrolide is the treatment. It's not amoxicillin. So the answer is obviously azithromycin. So if you don't know Arcanobacter, ARCANO, correct? You can read about it, but it's the mimicker of a strep in a negative strep. Okay. And I'm not suggesting that a negative strep couldn't be a viral illness either. Don't misunderstand me, but that's not the tenor of this question. I mean, there's nothing there that says do nothing. And with this in mind, especially since it's growing something, it's not viral. And had viral been down there, the growing something that pushed you away from that. Okay, 21. Most of you got this, I think. A 5-year-old. You know, this is just data on what is the bad thing about HUS. And you know that of the following, the boys at risk of HUS will be increased if. Now, it talks about the risk of development. It's not talking about necessarily the risk of the side effects or the comorbid state. Because I would agree that you wouldn't do antimotility agents, but of the question, the risk is increased in a GI illness that you're giving antibiotics. That's why we don't just give antibiotics for diarrheal illnesses. That's why you many times won't treat salmonella, because you know the data behind that. Shigella is always a problem because you do treat Shigella and enteritis. And you just have to understand that's medicine. It's not black and white, it's gray. There's the risk of developing knowing Shigella-like toxin, but you do treat that. You don't salmonella based on all these other issues. And of course, this would be E. coli 157H7 classically. So the way the stem of the question goes, the risk for the development of would be increased if the kid has been on antibiotics for his diarrheal illness. 22. This is a girl, 18. You go through this and you just understand the many different manifestations of mycoplasma. You know, it can give you an exudate. It can give you a pharyngitis without exudate. It can give you some lung sounds, fever. She's had it a while. She got amoxicillin, didn't help. Again, use the fact that when they give you something and it doesn't help, that should say, well, of the answers, which ones would not be helped having gotten that drug? So in a backward sort of way, if you just had that database, then those answers typically come out. And if that's the way the question is. So of these, most likely you're going to give, and I know that erythromycin escalates there, and that's not a bad answer, but you would give this kid azithromycin for the presumed diagnosis of mycoplasma. Okay. 23. Most of you got this, which is great, because this could have been a little tough. You had to read this, and then you had to put together, of course, the cattle ranch. I mean, hello, in the summer, and all that's going on here. And of course, he's got brucellosis. And how do you diagnose brucellosis? And again, to establish the diagnosis, I'm not saying a purple smear isn't good to look at, but that wouldn't give you the diagnosis. I'm not saying a CBC wouldn't be a test you may do within the confines of working the patient up. But the question most likely to establish the diagnosis, and it would be a blood culture because it grows in blood cultures. So there you go. All right, so the answer is A. 24, 2-month-old, well-term infant has constipated. I think, this, as I think most of you got this, would be the stool toxin assay because he's got botulism. I think most of you got that. Now, 25 is a tough one. So let's spend a little time on 25. Once again, a couple of questions should come to mind. Maybe a couple shouldn't, but a couple should. So that always makes it tough when it's just not, hand in glove. So you got a 6-day-old, but it's in August, and obviously he's sick. And mother had a spontaneous vaginal delivery. They talk about her febrile illness that she had, important. They talk about, yes, she had group B strep, but she was treated. Again, and I understand that can happen and the baby still get group B. But again, within a stem of a question on a test, you would use that information to say it's not going to be group B strep. They don't talk about anything else that the mother, because I know as you read this at this point, you're thinking, well, what are the neonatal pathogens that the baby could have because the baby's sick and the baby's only 6 days old. I mean, that's kind of where my mind would be. So, of course, you go through your bacteria. It's okay, E. coli, we're with you. We may be with you with herpes. But they don't talk about mother having any vaginal lesions. I know that many, you don't see them at the time of delivery. And they did say a vaginal delivery. So you're going to have to work with this a little bit. That has to still be on your radar. Whereas if they had said C-section and you still were down to 2 answers of which herpes would have been one, because they said C-section, I would have gone with the other answer. This one, though, doesn't help you in that regard. They say it was a vaginal delivery, so we don't know about that herpes and vaginal delivery, so we can't just dismiss it. But we don't have a history of herpes in the mother either. So we got a sick baby. And as part of the sickness, you assess, well, what is the sickness? Is this sepsis? Is this meningitis? Is this metabolic? And within those, you have to go down even further. If it's infectious, well, what's involved? Well, when you see a little bit of tachycardia, tachypnea with clear lungs, so they're trying to say not pneumonia. He's got a heart with a gallop. And of course, he's not perfusing and his liver is down. What is that? Well, that's heart failure, right? I mean, that's heart failure. A lot of things could do it, but you have to say that's heart failure. So then you say, of the following, the most likely cause of this baby's illness. Well, once again, early group B strep is more just sepsis, right? I understand that it could be bad enough to throw you to heart failure, got it, but mother was treated. So I'm moving away from that. Herpes, well, here we are. Certainly we can have liver involvement with herpes, but do you connect the dots of neonatal herpes with heart failure? That's a little bit of a stretch for me. Not that it can't occur, but I don't like that combination. I'll keep the answer possible, but I don't like that combination. Hypoplastic left heart, well, that doesn't fit this baby with fever and all that. So that's out. So if you answered that, you're no. RSV, 6-day-old, this, no. So you go back and now you're down to B and C. And B is one of the enteroviruses. What is it called? It can be CNS, but it is one that now can do the heart, as opposed to that previous question, remember, with arbovirus, because it causes myocarditis. Well, myocarditis gives you heart failure. So of the two, I'm connecting those dots such that the most likely is going to be the echovirus infection. And mother obviously had it a week before when she had, her illness, and which is perfect for the baby. But if you answered herpes, it's not a bad answer. Like if you answered hypoplastic left heart, that just is not fitting this at all relative to fever. So I got it. But this is a tough question. This is where you have to intuit a little bit. Well, they didn't talk about she had herpes. They didn't give mother had many partners or was some sort of setup. And she had this illness. Now you could all say, well, that was her viremia from her herpes. Got it. So I'm not saying herpes is a wrong answer, but of the two, based on what I just tried to say with the myocarditis, that pushes you into the enterovirus, ergo echovirus 11 infection, again, which is classic in this age. So that not only is it just say enterovirus, if you read about echo 11, it fits it even better. So that's the answer. Okay, but it's a question.
Quick clarification or request for help, I guess. I feel like for me, I read the liver edge is decreased 3 centimeters, and I interpreted that as like it's not that it's lower, but that it's higher, and that threw me way off.
Okay, let's see. His liver is decreased 3. Oh, I see what you're saying. You're saying that decreased meaning you couldn't feel it at all because it was shrunk.
Right.
I see what you're saying. Yep, that's fair. I got it. I see how that's viewed. Yeah, perhaps that would have been better to say the liver edge is down 3 centimeters. Right. Yeah. I got it.
Thank you.
Okay. All right. And 26, Whitney, please. Okay. A 4-year-old boy presents 2-day history of fever, lights bothering your eyes. Here we go. Now, this is a tough question. Here's another tough one. If you get down to it, he's got a CSF. You got 320, 80 neutrophils for the protein. Glucose is fine. This is going to be viral too, right? He has been in camp. Here we go. And he got fever. And everything says, okay, he's got a meningoencephalitis. I mean, he's vomiting and headache, and decreased activity and fever and light photophobia. I mean, hello. Okay. So we look at the answers. Well, the CSF is not bacterial. That if you answered B, whoa horsey, you're going to have to, that's not a bacterial CSF. So that's not it. Viral culture, I mean, no, we don't even do that, really. So you're now down to ARBO and Enero and herpes. Well, okay. Look at it from, I'm at camp, and I've got it. And remember, herpes is a virus that occurs year round. It doesn't have a predilection for summer or winter, summer over any other month. So just the fact that you've got that, you don't have a temporal lobe presentation, you don't have RBCs in the spinal fluid because they didn't give it. Now, if you're going to say, well, they were there, they just didn't give it to us. Now you see you're making it, the question won't fit your answer. And you're going to have trouble if you try to make that be that way because of something not there. And you know that herpes is a classic hemorrhagic meningoencephalitis, so you should have some red cells. No red cells there, so herpes is coming off. So now we're down, like the previous question, between an enterovirus and an arbovirus. And I understand that. And both are reasonable. So if you answered arbo, I got it. It's not bad. It doesn't mean you weren't thinking. It doesn't mean that you can't assess for what this is. Now, if you answered bacterial, we need to talk, okay? But if you answered arbo, I got it. But what's in the stem of this question that helps you with the most likely answer of it being your enero and not your arbo? And I put this question in here to show you the point I'm making. There's really only one thing, and that is his throat is erythematous, that he's got pharyngitis. Now, I know somebody's over there flipping through and realizing you can have maybe a little sore throat with RBO, and you'd be right. But it doesn't generally have a pharyngitis as much as an enterovirus does. Coxsackie, sore throat. So that is really what you have to read, and that is your discriminator, and that's tough, and I got it. But that's it, because really it could fit an ARBO. ARBO, again, therefore is not a bad answer. But for the most likely, you have to read that one line and see that he's got an erythematous throat that pushes you toward the enterovirus, which is the right answer. Okay? Just shows you how you have to read the words. You can't ignore, oh, he's got a little sore throat. I mean, go on. You have to cognate on it. You have to let it get in there relative to the overall. And I know you're reading and it's got sore throat, and it doesn't seem to want to take a big deal, but it is a big deal. Now, you can go the opposite way here, and you can get it, you can look, it's not this, and get down to those two and say, okay, now wait a minute. What is in the stem of the question that can separate A from C and go the other way? And then pay attention to nuances of things that might help separate. The fever's not going to help you, right? The spinal fluid isn't going to help you, okay, etc. So the encephalitis versus meningitis versus meningoencephalitis isn't going to help you. So that's the only thing left, okay? Tough question. All right, 27. 2-year-old ED with a simple febrile seizure. I think everybody knows, roseola, human herpes virus 6. That's kind of a given right there. So that answers E. 28. This is just knowing about rabies and who gets prophylaxed, and if they're even found in a room with a dead bat, the child should get prophylactic, should be treated for herpes exposure. So of the following, the animals that are most associated with human rabies is bats, hence why we have to treat them. Of those answers down there. Okay, next, Whitney. All right, 29 is a 2-year-old limbic. Now, this is a good question. I think most of you got it. And of course, why did you get it? Well, to get it right, you have to know, well, what is the bug? So you've got a kid essentially with a septic arthritis, right? Okay, and he doesn't have osteomyelitis because there's no bone involved. And you get stuff out, and he's got pus, so big deal. You knew that. Okay, and the culture is negative after 3 days. Okay, now, and he's getting IV Vinc. And once again, here's a question. He's getting a treatment for what you would have thought would have been staph. So what is telling you it's not staph? So what's the other big bug where you don't get better on vancomycin that gives you a septic arthritis? And that's Kingella kingae. And that's a database that you should know that. That's just an organism you should know that does this. But then to get it right, you have to go down next as to how do you treat it. Okay, and cefotaxime would be the answer of the answers that are there relative to getting it right. The change to clindamycin you would say, okay, well, this is a staph that's resistant to Vinc, I understand, but the culture is negative after 3 days. Then it should still be growing, and then the sensitivity should come back. So some of these things come out, and then trimethoprim, what's that all about for joint infection, really? For staph, linezolid, well, goodness gracious, that's a big gun. And just continue the Vinc? No, he's not getting better on the Vinc. You just wouldn't continue it. So this answer is C. And the last question, a 14-year-old, otherwise healthy, it's a rash, it looks like PR. That's what's being described here. And you should know that anytime you see PR in an adolescent, you at least have to ask the question about their sexual activity. this goes ahead and tells you he's sexually active. So you don't even have to worry about whether it's in there or not. And you know, the mimicker of that is going to be secondary syphilis. So you want to obtain serology for syphilis, which is the answer B. Okay, so there you go. Read on things you missed. Please look at why you missed what you missed. And hopefully also glean from this not only a database answer, but test question nuances, what's in that question, how the nuances there relative to how it may or may not impact on helping you with a negative or a positive ruling in or ruling out answers. All right, so we've completed the year now. I think that Dr. Carney is putting together a kind of conglomerate of board review next month, which will, I think, take a lot of what we've done individually, along with some other stuff that he's developed and I've sent him regarding board review stuff that I have taught in the past, other places, Indo, et cetera, that may be used. So there's more to come, but that will come from him. And then we will pick up again, I think, in August, and I think it's Derm. So hopefully this has been of some help to y'all, but you've got to do your due diligence too. You've got to be sure you understand what you don't know and work on those things, and be sure that if you did get it right, you know why you got it right, and it wasn't just a stab in the dark. Okay, any other quick questions I can help you with? Whitney, thank you. And again, talk with y'all later.
Thank you, Dr. Stallworth.
All righty.